Today, for you, mini lecture series is a case review for postpartum septic shock. And our guest speaker today is Kathy Halwick. And so I hope you can all help me in welcoming Kathy to offering us this wonderful education. All right, so we'll get started. Kathy, just a heads up, you are muted. And I'm going to hand the mic over to Kathy with this next slide, and then I will continue presenting.
Can you hear me?
Yes, we can hear you.
Okay, great. Thanks for having me. I just wanted to preface the discussion on teams to just refresh everybody's memory, just to maintain quality assurance privilege afforded by the New York State Education Law and Public Health Law. I want to just remind you that we don't want to share this screen or except for IV recording this by anybody else. And then also just remember that the chat box where I just wrote "You're welcome" is not to be utilized for messages that have any PHI in it. So, for example, if you think you know a patient that we're talking about, you don't want to write anything in the chat message that would connect that. Okay. All right.
Great. So before we get started, I really wanted to give you guys a heads up on how to easily access the sepsis policy via Policy Tech. And I know that Policy Tech isn't an easy interface to navigate. So if you double click on your Policy Tech and right over here in your search engine, you're going to write sepsis. If you scroll all the way to the bottom, 3 policies up, you're going to find that sepsis protocol. And this sepsis protocol essentially reviews all of the patient care, patient populations that we offer here at Northern Westchester Hospital. So you're going to find the pediatric population, the adult population, and also the OB patient population. And they will go through all of the SIRS criteria that is also listed to you in that Budge Buddy that we gave everyone within the unit. I'll review the badge buddy as well in this presentation. And so the reason why our patient population is so complex is because pregnancy physiologically impacts the woman so differently than an adult patient. And so I am not going to go in depth with any of this because this is just a bird's eye view of the physiology that occurs. But essentially, our pregnant women present to us differently with the SIRS criteria. And so sepsis is a continuum. And so what we hope to do is to stop the continuum, intervene, and monitor. And we want to monitor to see if our interventions are effective. And so what initially may present as SIRS will then, if we don't stop it, continue on to sepsis, severe sepsis, and septic shock. And so what I sometimes hear a lot is staff coming up to me and saying, "Hey, Ivy, I really don't know exactly what to do when we call it code sepsis." And my response to them is, that's okay. I don't expect you to know exactly what to do in these scenarios. What I expect you to do is to look down at this badge buddy to help guide you. And so if you suspect an infection, that's the key component here. If you suspect an infection and you have 2 SIRS criteria, they're bulleted right over here, you're going to broadcast to the LDR team. And what that does is it brings your own team to the bedside to help you navigate this emergency. Your next step is going to flip that badge buddy, and I need you to anticipate what the next steps are going to be. And so with that anticipation, you are going to draw your blood. And so a physician needs to put these orders in, and I guarantee you, they too are flipping this badge buddy over to help navigate what orders they need to put in. And so you're going to draw your bloods. I just want you to be mindful that for blood cultures, you are drawing 2 different sets from 2 different sites, aerobic before anaerobic, and then and I understand which one is that, Ivy? Is that the blue one or the purple one? I highly recommend you to just read what the bottle says, because if the manufacturer ever flips the color code on the top, you don't want to be filling the wrong one. And so you don't need to memorize that. You're just going to look over here and it says it, aerobic before anaerobic. Anticipate that we're going to be giving a good amount of fluids, and the physician and or yourself, if you're up for it, can do the math to see how much fluid we're going to administer. So that's 30 mLs per kilogram, and know that you're going to be giving antibiotics. And so that team is coming to help you with all of these interventions. Please be certain that you are drawing your blood cultures before your antibiotics. And I'm just going to flip back. And so if we have not caught it over here and the continuum were to continue, you are then catching it here over severe sepsis or septic shock. And your intervention is going to be a little different. Yes, you are still going to broadcast to the LDR team, but your physician is going to need to consult with other specialists, that hospitalist, the MFM, and the neonatologist. So I just wanted to give you guys that background. So when I hand this over to Kathy, you have a little bit more of a foundation.
Okay, thanks, Ivy. That was great. Great reminder. So we're just going to quickly review a recent case. We had a 39-year-old female, gravida 3, para 2, who was at 38 and 6/7 weeks pregnant. She arrived from home on the 30th of September at about 21:15. She had spontaneous rupture of membranes, but was not contracting. She had a history of Hashimoto's, fibromyalgia, anxiety, and group B positive strep. Past surgical history was negative. So at 22:28, 10:28 p.m., her blood pressure was 118 over 77, her heart rate was 113, and her respiratory rate was 16, temp was normal. At 23:15, they administered penicillin for her group B strep status. And then the next day, at about 17:32, the live female was delivered, and shortly after, the placenta was delivered. At 18:15, we have a temp of 101. We have a heart rate of 135. Okay. And as Ivy just reminded us, those are our two SIRS criteria. And we have 1833, a white count of 15. Now, if you look at the purple, the Northwell OB sepsis definition, temp over 101 and heart rate greater than 120. So we really only have the one. This is the difference between a regular person versus somebody who is pregnant or just gave birth. And the OB criteria for your white count is greater than 17. For non OB patients, it's greater than 12. So at 1817, there was a rapid response called for pallor, upper extremity stiffness, and the patient appeared slightly detached. At 1905, they had drawn a lactic acid and it resulted as 6.6. Now, in the world of non pregnant women who just did not have a baby, that's a very high lactic acid. We would consider that organ dysfunction and bringing us into the diagnosis of severe sepsis. And all you need is lactic acid over 2. And then at 1944, the Dr. OB documents endometritis. So if you look at that as a whole picture, we've got A for infection. We have, by non-OB definition, 2 SIRS, and we have organ dysfunction, lactic acidosis. So do we have sepsis? Do we have severe sepsis? Do we have septic shock? And if yes, what is our time zero? So in the non-OB world, our time zero here would be the whatever came last, which would be the 1944. So on 10/1 at 1944, in the non-OB world, we would have severe sepsis with a lactic acid greater than 2, but in fact, we'd have septic shock because the lactic acid is over 4. As an aside, that's why we don't routinely draw lactic acids in a just postpartum woman. Okay, next slide, please. Okay, so for sepsis, you must have an actual or presumed infection. On top of the infection, which we know was the endometritis diagnosis, we need the 2 SIRS. So there you have it. The times were 1815 for the SIRS and 1944 for the infection. To move you on that continuum from sepsis to severe sepsis, there needs to be an organ dysfunction. There are multiple ones to choose from, which we'll briefly talk about. But in this case, it would be the lactic acid. And then you pop into septic shock from severe sepsis by three different criteria. You either have a lactic acid over 4, or you have persistent hypotension, which means 2 hypotensive blood pressures in the hour following the completion of the bolus. The third way you would have that is if a physician wrote septic shock. That just automatically puts you into that bucket. And again, we said the time zero would be that last piece of the puzzle, which here would be 1944. Okay, next slide, please. So now what? If you think your patient meets criteria for septic shock, what do you do next? So Ivy talked about it already. We're going to call the code sepsis. We're going to perform an assessment, including our frequent vital signs, your heart rate, your blood pressure, respiratory rate, O2 sat, temperature, and you want to check the patient's perfusion. You want to prepare to give your fluids, prepare to give your broad spectrum antibiotic, prepare to draw your bloods, your cultures prior to the antibiotic, the CBC, the chemistries, including lactic acid. And then consider what else might be causing your lactic acid to be 6.6. Normally, in a non-OB area, when somebody has the lactic acid greater than or equal to 4, they look super sick, and their blood pressure 9 times out of 10 is really very unstable. Okay, next slide, please. So we're going to take a look at a quick breakdown of our 3 and 6 hour bundle components here. Did we meet all the bundle requirements for a patient with septic shock? So here we go. I don't know if you can do a pointer if you want to. You have antibiotics. Yes, we gave antibiotics. We gave blood cultures. We ordered was and delivered was the 2,500 of fluid. So you see the IV ordered, IV absorbed. The lactic acid was drawn in the appropriate amount of time. And then we go into our 6 hour components. We did not have any hypotension. The lactic acid number 2 was drawn in an appropriate time frame. And then what we expect when we have hypotension, which we actually didn't have here, so I'll make that a caveat. But if you're giving 30 per kilo of fluid to anybody, we want to know what happened to that patient after that. That's a lot of fluid. Sometimes it could put somebody on the verge of CHF into CHF, et cetera, and so on. So we want to see an assessment. And there's a required assessment that has multiple aspects to it, 5 specific aspects that after the fluid bolus, the physician needs to document. And so we didn't see that in this patient. However, that's only necessary and required after you have hypotension, which we did not have here. So essentially, we met all the bundle requirements for this patient for septic shock. So next slide, please. Shortly, so 1944 is our time zero. Shortly later, not even a full hour later, the hospitalist who was consulted for the code sepsis documented the lactic acid can be attributed to the recent delivery, so not likely to be related to sepsis. So because of this documentation, we do not use lactic acidosis as an organ dysfunction. The patient did not have any other organ dysfunctions, which we've listed down below here for you. So they no longer meet criteria for severe sepsis or septic shock, only sepsis with infection and the 2 SIRS. So the organ dysfunctions for that would push you into a severe sepsis category is a systolic blood pressure less than 90 or a MAP less than 65, the need for non-invasive or invasive ventilation, so that's your CPAP, BiPAP, or intubation. It's a creatinine greater than 2. It's a Billy greater than 2. It's platelets less than 100,000, or it's an INR greater than 1.5 or PTT greater than 60. Okay. So those are some of the things we look for when we're trying to figure out if we have severe sepsis or septic shock. I believe those are all on your badge buddy. Okay, next. Is that it? That's it. So questions. You can write them in the chat or you can unmute yourself. Does this make sense to everybody? Thumbs up. There's little emojis you can do down here. I'm going to give you all a thumbs up for listening.
Nice
all
talk,
right.
Kathy. I enjoyed it. Thank you.
Yes, so these mini lecture series are designed to be short and concise so that you guys can uptake that information, because we find that when we start presenting for too long, it gets challenging to do so, uptake that knowledge. So if anybody has any questions, that'd be great. And if not, then we are all set with our presentation. Or if anyone has any situations that we're in that they just didn't understand, by all means, this is a safe zone, so you can bring those forward.
I have a question, Ivy.
Great. Yeah, what you have, Sarah?
What is an appropriate time to draw the lactic acid? If you draw it immediately postpartum, and you're suspecting septic shock postpartum, are you going to get a higher lactic acid just because she is postpartum?
Yeah, you probably will, but that's up to putting that whole picture together to figure out how to better manage and treat that patient. And that's why we do involve a hospitalist or consult with them, because it does get tricky in our patient population. And it's been tricky for so long, but at least we have a red flag up and we have our attention on it, and we're able to monitor her more effectively.
Okay, so it's not wrong to draw the lactic postpartum.
Correct. It is not wrong.
And then what is an appropriate time to draw it after the initial one?
Yeah, so once you suspect infection and you hit your 2 SIRS criteria, you're already going to start the catalyst of trying to intervene.
Okay, so okay,
Are you, Sarah, are you asking the question of the repeat lactic acid?
Yes, the repeat.
So the repeat lactic acid can be drawn, well, it has to be drawn by the 6-hour mark, right? But
Okay.
it can be drawn at any point after you have started the fluids. So what we like to see, more importantly, is after most of the fluids have gone in, you want to see what that effect had on your lactic acid. So that we would suggest drawing it uh, within 2 hours of the first one, because usually you're giving a bolus and usually the bolus is going in over an hour.
Okay, thank you for clarifying.
You're welcome.
I see a good question from Fran on our comments. What does SIR stand for? So it stands for Severe Inflammatory Response Syndrome. Sorry, SIRS.
Hi, it's Angela. Can I ask you, when is the patient considered now stable? Once she does not have a temperature for 24 hours or some other criteria?
That's an excellent question. So I think it doesn't necessarily go by temperature alone. It's by putting also the whole picture together, inclusive of blood pressure and your assessment. And so, yes, the temperature being afebrile for 24 hours is an excellent feature to have, but I wouldn't say that you need that in order to consider someone stable per se. Does that make sense, Angela?
It does. Thank you.
Great. And yes, Tracy, I see your comment. We are actively recording. And so as soon as we're done, I'm going to send it out to the team. Alrighty, guys. Thank you so much for joining. And I hope to see you soon in our next little mini lecture presentation. Have a good one.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.